I think this is a really good example of, and we've been kind of saying it throughout the conference, that when you look at Angelman syndrome and Dup15q, like when we started our clinic back in 2011, we already had the Angelman clinic in place, and it was easy because it was the same stuff. It was seizures, it was sleep, it was GI, it was development. So it's the same domains, same genes, same domains, but different. So whether you have too much or too little, it's different, but it's the same stuff. You're not dealing with endocrine and all these kind of other weird things. It's the same exact domains, like I said, but it's different different presentations. So starting with Dup15q, and this I have to give Olivia credit for the slide. I have no idea how to do this on PowerPoint, but this is a really nice chart. So it starts with our at the time that we pulled this together, we had 67 kids with either classic isodate-centric or interstitial that we had good reliable sleep data on. And so the numbers, and I think it was kind of fun to do it this way. When you kind of look down the sheet, there's no sleep issues, 25 kids, and had sleep issues was 42 kids, and so that kind of goes against what we've been saying. But when we really kind of looked at it, half of those that really had sleep issues, they were mostly due to seizures, and so they weren't true sleep dysfunction. It was really seizures just making these kids not sleep. We had 4 kids who had really severe psychiatric disturbance that made them not sleep. Then we had some that had like really obstructive sleep apnea. So when you kind of pulled it out and kind of separated the clear medical cases and just was a plain sleep dysfunction, it was about 25%, which is kind of what we're seeing, and really not that much different from the general autism population. What we see is trouble falling asleep, nighttime waking and early waking, kind of the classic issues. So those from our clinic. This is from the clinic's database, compliments of Dr. Reiter, and so these were. And of course, we're a little embarrassed that the clinics that aren't mine or Shafali's are the ones that contributed this data. But again, just kind of looking at the the number of individuals that have certain issues. Again, kind of pointing to the same issue. So blue is usually, the dark brown is rarely, and the light brown is sometimes. And so the first group, some child sleeps about the same amount each day, so it usually does, which is great. Awakes once during the night, so it's really kind of split between usually, sometimes, and rarely. And then at the very end, child suddenly falls asleep in the middle of active behavior, so it's kind of more like a narcolepsy kind of thing, very rare, as you can see from that. And this is from Shafali's data looking at the CBCL, which is a very commonly used, well-validated measure looking for sleep. And this is kind of the common question: doesn't want to sleep alone, trouble getting to sleep, nightmares, resists going to sleep, sleeps less than most. So kind of just some really kind of classic sleep questions. And what she found was that there were some kids that really met criteria for kind of classic sleep disturbance, but most were just under it. So they weren't way down at the bottom saying there was even no whiff of a sleep disorder, but really most kids came out to like a kind of a subclinical range. And then this is from the Orlando group. So which she pulled out epilepsy versus non-epilepsy, and as you can see, there wasn't a huge difference. Again, against the severity of the epilepsy makes a difference as well. And then this was from our clinic. So we did have a paper, a larger paper that was multi-center, but just from the ones that we had 18 kids with isodate-centric and 8 with interstitial. Not that just had EEGs, but that actually slept during their EEGs, so we had that kind of sleep data. The ones that were clearly like not counting epileptic spikes, just had kind of a normal background. Only 6% of the isodate-centric we would call it kind of a normal EEG background, whereas about 40% of the kids with interstitial. And it was mainly background slowing that these kids had. So we pulled the beta frequency stuff out just because that's a kind of separate issue. I knew that was going to be a huge talk on its own. But theta frequency awakening, so that was an interesting one. It wasn't just plain arousals. They have this very kind of classic frontal arousal rhythm that kind of pops up. And just some really kind of very unusually structured arousals. They just had this very kind of high frequency theta activity when they wake up. About 17% of the isodate-centric folks and 38% of the interstitial had benign sleep myoclonus, so kind of clear twitching on the EEG that wasn't associated with clear twitching on video that wasn't associated with EEG findings, so they weren't myoclonic seizures. And then focal slowing. So again, the isodate-centric kids can have that kind of classic multifocal epilepsy. So it was, we saw more focal slowing there, less on the interstitial kids. And for as far as the spikes, again, more than half of the kids with isodeccentric had focal spikes, less of the interstitial kids, kind of going down. What was interesting is, so none of the kids with interstitial had status epilepticus of sleep or high amplitude spikes. I think I have, yeah. So this is the paper that we put out a little while ago. It was 5 centers, 5 clinics with 5 Dup15q clinics. So it was us, UCLA, Memphis, Minnesota, and Oren's group in New York. We saw a third had the alpha delta sleep, which is that first slide on the left there. So I think Shafali mentioned it yesterday. It's basically slow wave sleep, which we see in everyone basically that has slow wave sleep, and then with this kind of faster alpha frequency on top of it. And then these high voltage spikes. So the first kid that we saw had just a terrible epilepsy, had these spikes, and I said, I've never seen these before, this is very strange. And then the next kid that came in that had bad epilepsy with Dup15, I said, I've seen that once before in a kid with, and it's to the point now where if I have a kid in the monitoring unit and that's scrolling up on the screen, one of the fellows will walk in and say, oh, it's one of your kids. I'm like, yeah, it's one of my kids. So it's a very distinct signature, and we don't know what it means, but it really, kind of like the beta, it kind of sticks out in terms of Dup15, and so that's one of the things moving forward, trying to figure out what that is. And then the other one is sleep-activated discharges, or ESCS, so greater than 50% of the sleep pattern is filled with spikes. And that's well known in the epilepsy world that when you see that, it really leads to cognitive delays and just all sorts of developmental issues. And then we only had 2 kids with polysomnography, so this is something that we'd love to see more of. It's hard to get kids to stay in a sleep study all night, but we did have a couple. And they both had decreased REM for age. They both had frequent arousals throughout the night. They both had the beta activity. The question is there less kind of standard sleep architecture? Are there fewer spindles in K-complex, this kind of classic stage 2 sleep architecture? I didn't go back. It's hard to go back and, something we probably could do is go back and check and see like how many throughout the night, like how often they were happening, but they did exist. They weren't obscured by the beta activity. And then one had a little bit of focal slowing. So, so treatment-wise, in addition to what we saw with only about 25% kind of similar to autism, kind of general autism spectrum, the sleep issues tended to be easier to treat than other genetic syndromes. The 18 that required treatment, they all tried melatonin first, and a lot of them had a response. 61%, it really helped. Helpful for just falling asleep was another 11, so almost 3/4 had a really good response to melatonin, which is not usually the case for a lot of these kids. And then a 1/4 weren't helpful. For the ones that wasn't helpful, we tried a few different medicines, gabapentin, clonidine, clonazepam. Actually, I didn't put the kids on clonazepam. Ed would be mad if I did, but they came to me on clonazepam. And then with varying degrees of success. And a couple of kids had some help with behavior techniques, so they're always, there's always a behavioral component to the sleep, but we think in these syndromes there's definitely something wired in. So the next steps are, we're thinking of some more standardized clinical measures. So a lot of the data we have so far, the questionnaires are helpful. The clinic data that we have is more just kind of parental reporting and clinic notes, but more standard measures, and then actigraphy could be really, really huge. It's more of a kind of like the polysomnograms, but easier. It's really a more objective. You can really see how many times they arouse, and really even kind of what we call like a poor man's actigraphy. A lot of kids wear Fitbits, so you put the Fitbits on and you can tell when they move a ton, like you can see that like they're actually awake and arousing, so you can kind of get the arousals. And in some kids, if they're having nocturnal seizures, if you kind of catch it right, you'll see the heart rate kind of the same, and all of a sudden you see a spike in heart rate, and you're like, that's probably a little seizure in sleep. So it can almost be a measure of nighttime seizures. So it's kind of that's a technology that's really evolving, and I think that might be something in the future that that can really be, and most kids will wear a watch. They won't wear the whole spiel, but they'll wear the watch, so or the Fitbit. And the examination relationship between sleep disturbance, both the actual clinical sleep and the sleep architecture, and its effects on development, cognition, like everything. So what, if they're frequently arousing, if they're not getting enough sleep, if their EEG electrically isn't showing good, spindles and vertex waves and stage 2 sleep, what effect, like how does that directly affect it? We know there is some effect, we just don't know how much and what domains are most affected. But there's lots of things to look at. And then moving on to Angelman syndrome. for all the Angelman folks in the room, I'm sure you saw that was probably not your experience. So sleep problems are described in the diagnostic criteria, and I went through some of these slides, so I'll go fast, as 20 to 80%. Like I said yesterday, it's probably closer to the 80%, not probably, it is closer to the 80% than the 20. Various caregiver reports range from 40 to 80, but it's probably somewhere in the middle there. The sleep issues are more common in children with AS than other healthy children, and also non-AS related developmental disabilities. So whereas Dup15 is either around the same as kind of autism spectrum in general / developmental disabilities, or maybe even less, probably even a little bit less, with Angelman it's more. And so sleep problems are multifactorial in any kid, especially with developmental disabilities. But in Angelman specifically, that's where, as opposed to the excess GABA, the GABA receptors in Dup15 that may be leading to that signature, in Angelman there's decreased GABA receptors. They're deleted, they're mutated. So definitely the GABA transmission seems to be playing a role, and now there's also evidence in some animal models that UBE3A itself is directly affecting the sleep cycle. But beyond that, you can't just look at genetics and look at the molecular piece. Other factors, so epilepsy plays a big role in sleep. Kids that are seizing, they don't sleep well. Some medications will make kids stay up. Lamotrigine is a kind of a classic one. It can cause insomnia. It's a great medicine, but that's one of its downsides. GI symptoms, and this is a big one, and what we see is, I think I mentioned yesterday, when you kind of lay down and you're having reflux, it gets worse. So kids that are constipated, they're gassy, they're refluxing, that's going to wake people up at night. And so that's one of the first things we ask when we see sleep, when we hear about sleep issues. Do they wake up crying? Do they wake up screaming? Do they wake up burping? And if they do, then you're really not going to get much out of melatonin or even another medicine. You really got to, you got to fix that belly pain, because even though these kids can't really talk, they're telling you something. They're waking up and they're crying, they're screaming, they're telling you like something hurts and we need to fix that. So you have to really kind of look at what happens when they wake up. If they're just happy and playing, they're probably not having GI pain. And also anxiety, especially in the older folks. They get anxious. They don't want to be away from their parents. Okay. Oh, 2 minutes. Yeah, almost done. So just real quick, as I mentioned yesterday, about 60% in the study that we did, which was a parental questionnaire study with a very significant correlation between sleep disturbance and epilepsy. Again, so since I did these yesterday, I'll just kind of fly through them. About 80% of people in that study had tried sleep meds. It might even be more. And again, melatonin is usually the first one used, and there are a couple of studies that show that it's that there might be some decreased melatonin in kids with Angelman, and that anecdotally, the other ones that have been used, not so much your Ambiens and other kind of hypnotics, it's more kind of safe, easy ones, trazodone, gabapentin, clonidine. Unlike Dup15, we do use benzos for sleep. It's definitely safer. And this is a study that Anna Larson had done a few years back that was recently published. What we see in adults is that there still are sleep issues, and this slide is, but compared to infancy, in her study about 3/4 had felt that it was improved, and compared to childhood, about 2/3 had felt it was improved. So even though sleep issues persist through the lifespan, they tend to be a little bit better. And that's another slide about the adult stuff. And then there's very few studies. Again, it's so hard to have someone with Angelman syndrome stay in a polysomnogram all night. There's a few studies. A couple studies from Italy, I think, are the two big ones. But again, it kind of supports what parents are reporting, that there's decreased sleep, fragmented sleep. So that's why our sleep folks use gabapentin a lot. It really kind of helps kind of decrease that fragmentation of sleep and really kind of keep sleep sustained throughout the night. That's it. It's like 2 minutes. So. Oh, Shafali. So any questions about this or Shafali's? Just so we can kind of do a group question thing. Of course, Larry. That's good. Yeah.
So
surprise.
That's a nice slide on new data. I think it's in our program.
Yeah.
So how, not the one that you used, but the one that showed that kids were awake for more than 100 minutes, and that group was separate from the rest of the kids who, in general, went back to sleep. So did you see that at UCLA and Boston at all? Did kids just anecdotal? That there were some kids who just were outliers. They wouldn't go back to sleep within a reasonable amount of time when they woke up.
Yeah, I mean that's actually most kids with Angelman, but in the Dup15 group, there's no, that's Dup15. So the kids with Dup15, there are a couple, and it's with those kids. At least in our clinical experience, the ones that were those kids that stayed up for forever, they were the ones that had bad anxiety. It was mostly the anxiety kids, but also the seizure kids. They get up, and instead of just being awake and going back, they wake up and they get anxious, and then it's over. Once they wake up and they have like a little mini panic attack, it's just not going to happen. So, but yeah, no, it's a great point. Yeah. 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 And yeah, and this is where activity is going to be really important as kind of things move forward, because exactly. Yeah, and if there's kids that are waking that you don't notice, you're not going to be able to report that. And speaking as a parent of a daughter with autism who just didn't sleep for 2 years, like some of those questionnaires that, and I filled out a ton of questionnaires, when you fill them out, it's like, is it a 2, is it a 3? It's like, so it's like our measures aren't great. I mean, the questionnaires are as good as we have, and the clinic data is good, but it's not standardized. So I mean, it's like getting actigraphy and really seeing, okay, like this tells us that that's going to be huge. Like what we have is great for screening. It tells us there's something there, and really the big thing, just the whole overall sleep in both groups, is just it goes back to the too much GABA, too little GABA is at least a big piece of it. We don't know what UBE3A does exactly if you have too much or too little, but something in the kids with Angelman makes them not sleep way more than the kids with Dup15, and there's reasons, Yeah.
Yeah.
Oh.
I got a 5-second comment. The GI complaints, one of the things that happens when you sleep is your GI motility slows. And so you're going to have more motility issues. If you have something sitting in your stomach, it's going to sit there and it's not going to move. If you have stool in your colon, it's not going to move when you're sleeping because motility slows when you sleep. So yes, you will see more GI symptoms. It's already slow, probably in these kids. It's slower when you sleep.
Yeah. Which is good. You don't want to be moving too much when you're sleeping.